So there is a case history. A 60-year-old man with history of asthma, chronic kidney disease stage 1, Sick-Sinus syndrome, coronary artery disease, scheduled for coronary artery bypass grafting. Okay. The pain management as part of enhanced recovery for cardiac surgery protocol which is planned. Which of the following medications, if used, is more strongly associated with increased cardiac morbidity in this patient? These 4 drugs, among these 4, which is the drug which can affect the progress badly?
Celecoxib, sir.
Celecoxib, sir.
Excellent, very good. It is number 4, celecoxib. It is what is celecoxib?
NSAID.
COX-2 inhibitor.
COX-2 inhibitor, specific inhibitors.
What is the problem with this? Why it is not recommended for ERAS?
Cleared by the
Bleeding.
kidneys.
Eh?
Eliminated through the kidneys, sir.
Eliminated. What is the cardiac effect? You can use it
Myocardial infarction, sir.
not myocardial infarction. It is notorious for QT prolongation. Okay, so it can lead to arrhythmias, VT, and VSIP, and all these things can happen. Okay, right. Next case scenario is 65-year-old man with no significant past medical history presents to the clinic for preoperative evaluation of left total knee arthroplasty. His vitals are heart rate 78, BP 124/72, respiratory rate 20, and temperature 98.6. ECG shows RSR pattern in V1 and V2. The patient had an ECG done 1 year ago, which shows a similar finding. What is the next step? The 4 options are: order for an echocardiogram, proceed with surgery, cancel surgery and order cardiac stress test, refer the patient to cardiology.
Order an echo.
Order an echo.
Any other answer?
Proceed with the surgery, sir.
Fantastic. That is the correct one. Because RSR pattern is right bundle branch block, V1 and V2. Is right bundle branch block innocuous or is it pathological?
Elderly, it is.
Mostly in normal. It can be ignored. Okay. So the answer
ECG
is,
was done 1 year ago, sir. So
that also shows the same thing. So there is no change.
okay, sir.
So it has been a persistent thing to show that it has been there for a long time. That is the reason it is given that ECG done 1 year ago shows a similar finding. So it is not come on suddenly. So that means it is one of the congenital problems which can be innocuous in the patient. Okay. An 80-year-old man presents with severe persistent pain in his left lower extremity. His history is significant of end-stage metastatic melanoma and complex regional pain syndrome of the left lower extremity. He is currently immobile and bedridden, but would desire improvement in pain control for the left lower extremity. Which of the following is correct regarding the use of alcohol neurolytic blocks when compared to phenol? The options are: the intense pain during injection remains localized to the injection site, no risk of neuritis, limited duration of action. We discussed this comparison between alcohol and phenol in the last school about neurolytic blocks. Which of the following is correct?
Intense pain.
Very good. So the answer is intense pain during injection is the drawback with alcohol neurolytic blocks. Okay, good. What is the dose of this drug?
2.5 milligram.
2.5 milligram per kg.
2.5 milligram. Is there a range or only a standard 2.5 for everybody?
2 to 2.5 milligram per kg.
And 2 to 3 milligram initial bolus, further dose of 1 milligram per kg. Okay. What is the composition of this particular drug?
Dantrolene sodium with mannitol.
Mannitol and only these two.
Sterile water.
Sterile water you
Is
have to
there
add. Sterilized lipophilicized powder of dantrolene sodium, mannitol 3000 milligrams, sodium hydroxide to get the pH to 9.5. It's highly alkaline. Okay? So the three things are there: dantrolene sodium, mannitol, and sodium hydroxide. How much of sterile water to be added?
60 ml of
60 ml. Excellent. 60 ml for each vial. How soon it should be used?
Within 6 hours of dilution, sir, at room temperature.
6 hours after reconstitution. Fantastic. What are the indications for its use?
Malignant hyperpyrexia.
Only malignant hyperpyrexia?
Neuroleptic malignant syndrome, sir.
Any condition which increases the body temperature and rigidity. Okay, treatment of MH, neuroleptic malignant syndrome. Even in thyrotoxicosis, you can use it. Okay. What is the mode of action?
ryanodine receptor. It will inhibit the
Receptor blocker. Okay. So it is a ryanodine receptor antagonist. What is the role of mannitol in this?
It maintains the tonicity of
Tonicity.
It's in solubility, sir.
Helps to make dantrolene water soluble. Very good. What is this? How does rhinodex differ from dantrolene? This is a
Usually it
new-
exists in powder form. This is a liquid, liquid form.
number of it is easy to reconstitute, sir. It takes few
Yes, sir.
takes
That
less
is 20
time for
milligram.
reconstitution when compared to
you
dantrolene.
can see the label here. It is written
sir,
250
250
milligram per vial. Okay, so you have to dissolve lesser number of vials for the compared to this. You may require about 40 to 60 vials if you use this, because each vial has got only 20 milligram and you have to give say 3 milligram for a 7 kg person. That means it will be 210 milligram. You have to dissolve at least 10 vials for this. Whereas here it is 250 milligram per, so one vial will be sufficient. Okay, as a higher concentration of dantrolene, 250 milligram vial compared to 20 milligram needs only 5 ml dissolvent, not 60 ml as you do with this. So reconstitution is also easy. That is why they are introducing the newer variety of dantrolene. This is the recent advance, so you have to remember this. What is an alpha 7 nicotinic acetylcholine receptor? Where are they present? What are the normal types of acetylcholine nicotinic receptors you have?
Muscular and neuronal.
nicotinic.
Solar and neuronal, very good.
Mature and immature
Mature and immature. Adult or infant, isn't it? Where
Yes.
the one composition is different. It's a pentameric structure, but here it is a alpha 7 nicotinic receptor. Present in the brain, neurons, and other parts of the body. What are their effects?
neurotransmission.
It's a ligand-gated ion channel that is important in central nervous system. So, what is the difference in this particular ligand-gated channel? What ion it permits compared to the other neuromuscular nicotinic receptors, which normally at the neuromuscular junction, what do they permit? Which ion is permitted through the channel once they open the gate?
Calcium.
Sodium ion.
Neuromuscular junction. Do they permit calcium?
Sodium.
Sodium. Whereas here it is the highly permeable calcium ions, which are important for neuronal behavior and survival. That is the most important difference. At the neuromuscular junction, they permit sodium ion entry, whereas the at the neuronal and brain cells, calcium is more important than sodium. So they permit the calcium ions and is part of cholinergic anti-inflammatory pathway, which is important for terminating the sympathetic nervous system activity and is implicated in long-term memory also. It is considered essential in pathophysiology of inflammatory diseases like rheumatoid arthritis, sepsis, and atherosclerosis. What are the types of acetylcholine receptors? Why are they named so?
Nicotinic and muscarinic.
Nicotinic and muscarinic. Very good. Why are they named nicotinic and muscarinic?
Nicotine is present in the
Cholinergic receptor divided into nicotinic acetylcholine receptors and muscarinic acetylcholine receptors. Why that particular name was given? Because these are the things which respond. They found that they responded when they injected this into the experimental subjects. Okay, some receptors responded to nicotine and some receptors responded to muscarine. What is muscarine? It's a toad poison. Okay, nicotine is present in tobacco. All of us know that. So, a nicotine extract and a extract of toad poison called muscarine were injected, and they found the receptors having different structures responded differently. So, the nicotinic receptors are responsive to nicotine, and muscarinic receptors are responsive to muscarine, which is a throat poison, and that is the reason why they are named so. How do they differ in their mode of action?
One is ion gated channel and the other one is
GPC.
G-protein.
G protein coupled receptor.
So nicotinic receptors are ionotropic, and that means activation of receptor leads to formation of ion channel within the cell membrane known as ligand-gated ion channel. Whereas muscarinic receptors are G protein coupled receptor constitute a family of receptors which generate a second messenger system when activated via ligand binding. Okay. What are the causes of error in pulse oximeter reading?
nail painting, shivering, hypothermia,
Carbon monoxide poisoning.
Hemoglobinemia.
Okay. Delay in response due to hypothermia, low carbon dioxide, low cardiac output to vasoconstriction due to drugs. Give a Raynaud's reading due to motion artifact and hypoperfusion, and it may also be because of the dyes and other things. Which technology is used to eliminate motion artifact and hypoperfusion?
Multi-wavelength.
So signal extraction technology is used to correct motion artifact and hypoperfusion signal loss. Okay, and this is used by what is Massimo Rad 57 oximeter? Question past. Massimo is a multi-wavelength pulse oximeter which uses 8 wavelengths to measure different speed spectrum of this. What is reflectance pulse oximetry? What are the advantages?
It has 2 points of fixation, sir. As the distance increases, depth increases.
It's a pulse oximeter which probes are placed on the forehead. Okay, and this avoids motion artifact and hypoperfusion signal loss. So it is like this. Okay. What are the other uses of pulse oximeter other than measuring the oxygen saturation?
Can
Pulse
we
pressure.
calculate pulse index?
Hmm.
Uh,
If it is associated with plethysmograph, then only it is other uses. If it is just a simple display of the saturation and pulse rate, like a simple finger probe, then it is of no use. But if it displays the plethysmograph, it may be used to measure the volume status and fluid responsiveness, and they can be also used during epidural test dose and administering to detect intravascular injection. So, what will happen if you use this during epidural test dose?
Adrenaline will cause tachycardia
Rise
more
and
than
heart.
20 beats per minute.
So, what is perfusion index? How is it calculated? What is its normal value?
Ratio of pulsatile to non-pulsatile blood flow.
Very good. That is perfusion index. How it is calculated is, what is the normal value for that?
20%.
0 to 20%.
Maximum 0.2% to 20%. It's a non-invasive numerical value of peripheral perfusion obtained from pulse oximeter. That is the definition of perfusion index. It is a non-invasive numerical value of peripheral perfusion. And the perfusion index is derived from pulse oximeter, which calculates the ratio of pulsatile flow to the non-pulsatile blood in the peripheral tissue. The value ranges from 0.02 to 20%. What is PVI displayed in the pulse oximeter? How is it calculated? You would have seen some pulse oximeters have a display called PVI, apart from PI, which is perfusion index.
Pleth variability.
Blood variability index displayed. How is it calculated?
Correlates with ECGs.
Respiratory.
Dynamic
Respiratory
is calculated measuring the perfusion index over respiratory cycle. Okay. So how the blood variability occurs due to response to, there will be a cyclical change because of inspiration and expiration. So that is how it is a dynamic index calculated measuring the changes in perfusion index during a respiratory cycle. What features of EEG are analyzed to get the BIS value? You want to get a BIS value, what are the features of EEG that are analyzed by the BIS machine?
amplitude and frequency.
It uses an algorithm of the EEG waveform considering the frequency, phase, and power spectrum to generate the BIS value. Three things of EEG: frequency of the EEG waves, the phase of EEG wave, and power spectrum. What are the applications of BIS monitor?
To measure the depth of anesthesia.
Depth of anesthesia. All of you know that. Very good. Anything else? One important application is to its role in preventing intraoperative awareness, otherwise depth of anesthesia. And it can also be used in the incidence of what is POD and POCD in patients.
Post-op cognitive delirium,
Cognitive
post-op cognitive dysfunction.
Cognitive differences. Okay. This monitoring also facilitates early post-operative recovery. Okay, based on that only you do that. How many electrodes are applied to the BIS monitor? To monitor the BIS.
4 electrodes.
4 electrodes. Very good. What is the function of the fourth electrode? All of them measure the EEG, or the fourth electrode measures something different?
Electromuscle activity.
Frontalis muscle. Electromagnetic myographic activity is of the frontalis measured by the fourth. It is also the ground electrode. What are the displays in BIS monitor? The monitor screen. What are all the things that is displayed?
Signal quality index.
And
Signal quality index. Okay. This value,
Numerical value.
Numerical value.
numerical unit dimensionless value. Okay. So this number, trend graph of this value over time, raw EEG waveforms in real time, various signal quality indicators like signal quality index and EMG, alarm indicators and messages. Okay, so this is the first thing is the BIS number. Then you have the EEG tracing. Then you have the trend graph of both the EEG and the electromyograph, and the menu, alarm signals and all these things. What is the effect of hypothermia on EEG and BIS? So patient becomes hypothermic. What will happen to the EEG? This value.
Waveform.
It is all about.
Decrease.
Reduction in temperature results in reduced cerebral metabolic rate reflected on ECG by the progression to an isoelectric or burst suppression pattern. Okay, the activity will become less. And this decreases by 1.12 units for each degree Celsius reduction in body temperature. Name any two depths of anesthesia monitors using EEG analysis.
Entropy, sir.
Entropy we can do.
Entropy and
Narcotrend.
narcotrend. Excellent. Spectral entropy monitor and narcotrend. Fantastic. A 21-month-old boy presents following the accident swallowing of a button battery while playing with it. He is in moderate distress. The patient is tachypneic and stridulous but maintains oxygen saturation of 98% on room air. What is the next best step in the management? Choices are flexible fiber optic laryngoscopy, transfer to operating room for direct laryngoscopy, immediate endotracheal intubation, stat neck X-ray to localize the battery location.
Neck X-ray.
Neck.
X-ray. This is a common thinking. Here patient is maintaining the saturation even though he is tachypneic and stridulous.
Flexible fiber optics.
Fiber optic.
Flexible
Laryngoscopy, sir.
Direct laryngoscopy.
Transfer to OT.
Transfer to OT and do a direct laryngoscopy. That is the easiest and that's the answer for that. Okay, so you can do that with the help of restraining the child and trying to do that. What is shown here? Where is it used?
Finger nose test.
Aldred score.
Aldred score is
Aldred
Modified
score.
Aldred score.
Modified Aldred score. Very good. Modified Aldred score is shown here. It's used to, where is it used? It is used to
Discharge
assess
rate.
patient readiness for
Discharge
discharge from
criteria.
post-anesthesia care unit. What score is safe to transfer the patient?
8, sir.
8.
No, they say score of equal
9.
or more than 9 is safe. Okay. Why is it called modified?
So initially
There was no
Saturation.
oxygen saturation.
It
sir.
has
There was no pulse oximeter to measure the oxygen saturation, so they went by the color of the patient's finger and lips and all that to see whether any cyanosis is there. But after the advent of pulse oximetry, they started using the O2 saturation, so that is why it's called modified. The original Aldred was developed before pulse oximetry was invented and used skin color as a proxy for oximeter. The modified score replaced the skin color with pulse oximetry measurement of SpO2. What is airway pressure release ventilation?
It is a new technique of ARDS,
Newer mode of ventilation.
newer mode of technique.
It is a use in ARDS, but what is airway pressure release? How do we define that? What exactly happens in it?
during expiration, the pressure is released.
Okay.
Minimize the
So
resistance.
it's a pressure control mode
High
of
pressure
ventilation.
and low
First
pressure.
First and foremost is it's a pressure control mode of ventilation that delivers almost continuous positive pressure with intermittent time cycle short releases at a lower pressure. Okay? So it is a somewhat modification of CPAP. Continuous positive pressure intermittently by a time cycle by short releases to lower pressure. That is why it's called airway pressure release. So the high pressure that is continuously given is on and off released intermittently. So spontaneous ventilation is encouraged in this mode. Relatively increased mean airway pressure allows for the improvement in the oxygenation. How is oxygenation and elimination of carbon dioxide done in this mode of ventilation? It uses long inspiratory times, which increases mean airway pressure. That is how it improves the oxygenation. But at the same time, brief releases at lower pressure facilitate carbon dioxide clearance. Okay? What is automatic tube compensation and what are the benefits?
It helps in weaning the patient. It helps in weaning the patient from the ventilation, sir. It compensates for the resistance offered by the endotracheal tube.
Or which other tube? Tracheostomy tube also. Okay. So it is called,
Yes.
that is why it's called tube compensation, automatic tube compensation. It's a ventilator setting that can help with breathing by reducing the pressure drop caused by an endotracheal tube or a tracheostomy. And ATC can help with reducing the work of breathing, helping patients wean from mechanical ventilation, preserving a patient's natural breathing pattern, improving synchronization between patient and ventilator, and improving respiratory comfort. Okay, so these are all the advantages of ATC. How does ATC work? How does it help during extubation? Because it's a closed loop system that compensates for the pressure drop that occurs during inspiration and expiration. So it can be used in combination with other ventilatory modes. The ATC can be effective as pressure support ventilation or a continuous positive airway pressure in predicting whether a patient is ready to be extubated or not. So it can be equal to these two methods. How does clinical decision support system, CDS, in electronic health records help in patient safety? Are you all aware of these terminologies?
Yes, sir.
So it can reduce errors and adverse events. This is a new thing, automatic recording of intraoperative events. The monitoring chart which we mechanically or manually fill up is now slowly getting replaced by electronic health record system. In that there is a component called clinical decision support system. That is, we help you to get a decision or make a decision of what to do in case of something going wrong. So reducing errors and adverse events, promoting best practice for quality and safety, improving cost profiles, responding rapidly to public health emergencies, supporting shared decision making, tailoring treatment plans to patient preferences, increasing adherence to clinical guidelines, helping clinician identify and intervene sooner with high-risk patients. These are the advantages of CDS. Which CDS tools provide timely information to help inform decisions about patients' care, which is another part of that. So there are computerized alerts and reminders, clinical guidelines, condition-specific order sets, focus patient data reports and summaries, documentation templates, diagnostic support, contextually relevant reference information. So these are all new things which are coming up, which are going to be the future, especially with the AI also coming into play. So you must be aware of all these things. And for what purpose CDS systems are used? are used for a variety of purposes, including laboratory and pathology and patient-facing decision support. These are all the areas where it can be of use. A 5-year-old girl is admitted to the hospital for an elective tonsillectomy. She weighs 20 kg. During the procedure, which is performed unevenly, intravenous fluids are commenced using sodium chloride 0.18% and glucose 4% at the rate of 100 ml per hour. She is discharged to the ward in the afternoon. Intravenous fluids are continued at the same rate. The next day, in the early morning, she develops a generalized tonic-clonic seizure treated with lorazepam. Which of the following is the next best step in the treatment of this patient? First option is measure the urinary sodium level. Second option, plasma electrolytes and glucose. Third, do a CT brain. Fourth, give intravenous 50% dextrose.
Plasma electrolytes and glucose.
Okay, why you want to do that? That's the correct
I would
answer. Explain the
suspect
selection of your answer.
hypernatremia.
Huh?
I would suspect hypernatremia, sir.
Hyper.
Hyperosmolar hyponatremia.
Hyperosmolar hypernatremia.
Hyponatremia.
This child has been given hypotonic fluid as maintenance regime. It has been administered at a high rate for a long time. The child weighing 20 kg using the 4-to-1 rule should have received only 60 ml per hour rate, but she has received 100 ml. And severe hyponatremia is the most likely explanation for the seizure. Plasma levels need to be urgently measured. Okay, the whole thing is a hypotonic fluid. Plus glucose will be immediately metabolized, it will become only water. And sodium chloride is here it is not even 1/5 of the normal saline. So it is a hypotonic fluid causing dilutional hyponatremia, causing this problem. A 51-year-old woman scheduled for cataract surgery presents for preoperative risk stratification. Her medical history is remarkable for well-controlled diabetes mellitus, hypertension, chronic kidney disease, and ischemic cardiomyopathy. Her surgical history is also very valuable. She has undergone a coronary artery bypass 3 years ago. She denies exertional dyspnea or chest pain. What is the best next step in the management? The options are proceed with surgery, exercise tolerance test to be done, dobutamine stress echocardiogram to be done, myocardial perfusion scan to be done.
Proceed to surgery.
Fantastic. Why? What is
Since
the
the
explanation?
metabolic
low-
equivalence functional capacity is normal, we can proceed with the surgery.
There is no mention about
Well
exertional
Needs
fitness.
exertional
Sir,
test.
whatever test, the exercise tolerance is not going to change. If it's not going to change the outcome of our planning, then there is no need to proceed with it.
The type of surgery is
It's not a high risk for
That is the correct answer. Answer for that is proceed to surgery. Explain is for low risk procedure, there is no reason to obtain preoperative testing. Patients can safely proceed with procedures regardless of the clinical history. Okay, that is the answer. Because it's a low risk procedure. Cataract surgery is considered one of the low risk procedures. What is goal directed fluid therapy? What is its goal?
Sir, wherein goal-directed fluid therapy, there is no replacement of fasting fluids. Only maintenance fluid is given. That too based on the goal like stroke volume index or pulse pressure index.
They are tools to assess your fluid responsiveness or fluid therapy.
Optimal fluid therapy perioperatively is.
So the actual definition for the first question, goal directed is it's a personalized fluid replacement method that uses hemodynamic monitoring to optimize cardiac output and oxygen delivery to vital organs. That is the definition of goal directed. It's a personalized, it is individually given for each patient depending upon the response. It is not a blanket so many ml per kg. It's not like that. The personalized fluid replacement method uses hemodynamic monitoring, especially the dynamic indices rather than passive indices. And where is GDFT used? Which situations it is used?
Sir, in
High
high
risk
risk
patients,
surgery where
cardiac patients, kidney
major
patients.
fluid shifts.
Mainly in ERAS technique, wherever you want to do enhanced recovery after surgery protocols. Okay, if major surgery is the key part of ERAS. How do GDFT work? How do they work? They work based on the hemodynamic parameters like heart rate, blood pressure, cardiac output, and what monitor systems are needed for GDFT? Can you do it with your regular multi-parameter monitor, or do you require something else?
We can go for CVP
Cardiac
monitoring.
Cardiac output monitoring with
Commercially available now. Which one you use during liver transplant or major procedures? Are you not using that? Flow track or Vigilio monitor.
flow track
Okay,
Vigilio.
it is minimally invasive and provides continuous beat-to-beat data which is needed for GDFT. Okay. What are the complications of hypervolemia? By blindly giving fluid at the rate of say 10 ml per kg or 20 ml per kg.
Pulmonary
Pulmonary edema, sir.
Due to interstitial edema, local inflammation, impairing the regeneration of collagen, and thus negatively affecting tissue healing and increasing risk of wound resistance, wound infection, and anastomotic leakage in intestinal anastomosis. What is CNAP? How does it work? What
Sir,
is the
it is
expansion for the acronym CNAP?
continuous non-invasive arterial pressure monitoring.
Very good, excellent. Non-invasive arterial. How does it work?
It has a finger cuff which measures the blood flow to the tissue
Excellent. So
continuously.
it is a inflatable finger cuff. So the finger's artery diameter is measured by an integrated photoplethysmography. Okay. And the pressure needed to keep the blood volume constant corresponds to the arterial blood pressure waveform. The new CNAP algorithm analyzes arterial blood pressure waveforms and it can respond to any deviations from the set point. This is how the whole thing will look like. So you have the finger cuffs here which are inflated. There is a machine going through that. And this is the monitor which is displaying all the parameters, the blood pressure, pulse rate, mean arterial pressure, the cardiac index, all the parameters you are likely to get with that. What is shown here?
Gastric LMA, sir. Used in endoscopy.
Intubating LMA.
Intubating LMA with a video.
The
Third generation. Yeah, you have this is an LMA part, but it has also got a video scope to see where you have placed the LMA. Okay, so it is a video laryngeal mask combining a second generation laryngeal mask with a video scope that is inserted into the tube of the laryngeal mask. So you can see all the parts here. A is the totally assembled video laryngeal mask. So it is called VLMS, video laryngeal mask scope. And the second part is it has been dismantled in B. You can see disassembled LMA with the laryngeal mass showing camera and light source arising at bowl and the top of the 3 orifices of channels for airway, videoscope tube, and gastric drainage. And C is the monitor screen attached to flexible videoscope via the control body. Okay. What are the features and advantages of this LMA?
It allows visualization of
Exact
Using
placement.
intubation.
Direct vision allows for better placement of the device and immediate correction of any issues. It is a real-time video, allows for confirmation of the device size and immediate correction of any. Supposing you have put in a bigger size or a smaller size, which is occupying or not occupying the oropharynx correctly, that can be corrected. And it is self-energizing sealing device, allows for higher inflation pressure, which can reduce the risk of neurotrachea, the pharyngeal nerves. What is the unique feature of LMA Supreme? LMA Supreme is a single-use second-generation gastric access device which forms an effective first seal with the oropharynx and an innovative second seal at the upper esophageal sphincter. That is called the esophageal seal. So there are two seals in there, which is unique to this. So the picture will be like that. First seal is the oropharyngeal seal. The second seal is the gastric seal or the esophageal seal. So this opening normally present in other LMAs will be just abutting into the point of entry of esophagus. Here this also has a balloon which will prevent any side leakage through the hole. So that is the uniqueness of this LMA Supreme. What is cuff pilot technology? Which LMA has this and what is the added advantage? No idea? Okay. Cuff pilot technology uses color coding to indicate the safe pressure while inflating the cuff of LMA. Okay. And this is present in LMA protector. And it is MRI safe. It can be used in MRI machines also. So just to give you an idea about this, this is the color coding. You have, if the pressure is up to green, that is safe. If it goes to red, yellow is inadequate, green is safe, and red is dangerous, too much high pressure. So this color coding will be there. Do you have any the same color coding used in any other gadget that you use? Think about it. Tell me next class. What is shown here and what property does the highlighted ester confer to this compound? This is a structural formula of a compound which is very commonly used and very recently becoming available in our practice. Introduced.
Chlorprocaine, sir.
So recently introduced. The drug has been coming into the market, to my knowledge, only last.
Tetracaine.
Remifentanil.
Remifentanil, yes, excellent. That is the clue. So this is the structure of remifentanil, and the addition of an ester group rapidly helps to be metabolized by non-specific plasma and tissue esterases, because this ester has to be metabolized. So esterases help to metabolize this drug. Okay. It gives rise to the characteristic ultra-fast offset and allows for rapid titration. What is the metabolite of remifentanil? How does it require dose adjustment in CKD patients?
It has no active metabolites.
What is the metabolite name? First part of the question is, what is the metabolite of remifentanil? Okay, it is called remifentanil acid. that is the metabolite, undergoes renal excretion but accumulates in patients with reduced renal function. But the dosing of remifentanil does not need to be adjusted for renal dysfunction as this metabolite is almost inactive. So no need for any dose adjustment. Okay, that is the answer. What are the clinical applications of remifentanil? We prepared this particular drug because it has come to market and people have started using in India. All along it was available only in the Western countries. Now this is available freely in our Indian market. So examiners may be fond of asking this question. Have you all started using it in MEOT and SIMS and other?
No,
sir.
not yet.
Not it. Why your seniors are not in favor of that? It's supposed to be a wonder drug with intraoperative analgesia. So very okay. Using during general anesthesia for intraoperative analgesia, intubation without muscle relaxant. They used to do that without for the fiber optic scopy and all that. They used this for awake fiber optic intubation. Patient controlled analgesia during labor and conscious sedation for procedures like dental extraction, fracture reductions, burns dressing, awake tracheostomy, bronchoscopy, all this failed regional block or regional block that is wearing off, all that can be managed with remifentanil. What are the advantages in using remifentanil in ICU sedation?
Context due to context.
Shorter contact sensitivity half time.
Oh, that is the character of that drug. But what is the advantage you gain by that short context sensitive half-life?
We can assess the patient.
Neurological assessment, early neurological assessment during sedation hold, ideal for resuming spontaneous breathing, no need to adjust dose in chronic or acute kidney injury, predictable offset time in patients with multi-organ dysfunction, and helps to avoid patient ventilated dysynchrony also. Okay, these are all the advantages. Can it be used in intrathecal or epidural routes?
No, sir.
Why?
It has glycine, which is an inhibitory
Fantastic.
neurotransmitter.
No, because it contains glycine as acidic buffer. What PCI pumps are used for remifentanil and propofol?
Med.
Elevels.
It's Minto model for remifentanil and Marsh model for propofol. Okay. So nowadays, every conference you go, you have a TCA or TIVA workshop, and you are giving training also in that. So it is all going to come in the future. So be prepared for that. Which NMDA under trial matches the speed of onset of motor blockade of sacramethonium? This is not coming to market. It is still under the phase 2 trial.
Gentacure.
But Gantacurium.
Gantacurium.
It's called Gantacurium, a new promising, but it is not a depolarizing blocker. It is a non-depolarizing neuromuscular blocking agent, which has all the qualities of succinylcholine with regard to onset and duration, without the side effects of fasciculations and hyperkalemia and all those things. What chemical class of drug is Gantacurium? Normally, non-depolarizers, what are the chemical
Steroid compounds and
Steroidal and
aminosteroids and this isophenolines. Okay, but the Gantacurium, does it belong to that or is it a different compound?
Separate ones. Not this.
Separate? No, what separate? What is that compound? Any idea? It's called the alpha chlorofumarate. It's an asymmetric alpha chlorofumarate compound. It is neither aminosteroid nor this isophenolane. And how is Gantacurium metabolized? It is by chemical degradation, same like your Hoffman elimination, and also by cysteine adduction. This is the unique property of that. You add a compound called cysteine and that it will get metabolized. Cysteine adduction is inactivates the molecule, and the metabolite of gantacurium show no new molecular properties. How is the block by gantacurium reversed? Unlike hexamethonium, which undergoes spontaneous degradation by the pseudophyll esters in the body, gantacurium requires reversal. That is the problem with that.
L-cysteine.
Can be reversed by administering cysteine. So it inactivates. So by using the same cysteine, you can inactivate it. Compare gantacurium with mivacurium. Mivacurium is also a very short-acting drug. So the comparison
Mivacurium
is
is metabolized by plasma clonists.
it's a chlorfumarate compound, whereas mivacurium is benzyl isoquinoline, just like your atracurium and tetracycline. It has a faster onset. Mivacurium compared to gantacurium is slower. This is a very short-acting drug, whereas comparatively mivacurium is longer acting. It has less histamine release, whereas mivacurium has more histamine release, and reversed by cysteine adduction, whereas mivacurium can be reversed by your neostigmine or hydroconium anticholinesterase. What is shown here and what law in physics is applied here?
Laplace law.
Laplace's law. Laplace's law. Very good. What is shown here actually? What law is correct?
Surface tension, sir.
Surface tension. Look at the picture and describe that. That is what you are supposed to do. There are two alveoli shown, isn't it? There is a common tube dividing into Y-shaped entry points, and one you see there is an arrow mark in green, another there is no mark. And this one where the arrow mark is showing shows alveoli without surfactant. There it shows alveoli with surfactant. So alveolar model of different sizes with and without surfactant is shown here. Laplace's law is applied here. So what does Laplace law postulate? What is the full name of this person, Laplace? Any idea?
No.
Name is Pierre Simon Laplace. Just like your Pierre Robin syndrome. He is also a French fellow. So his name is Pierre Simon Laplace. What does that law state? Laplace's law.
The
If the pressure
tension in the wall is dependent on the radius.
but the tension is inversely proportional.
Three things are compared here. One is pressure, another is radius, and third is the tension. Okay, the relationship between these three is made out in this Laplace's law. As you can see there, P is equal to TTAR. Okay, so the pressure, how does it change with the in relation to tension and radius? That is what is being described in this. So Laplace's law states that pressure inside a sphere or a tube is inversely proportional to the radius. That is, if the radius becomes longer, pressure becomes smaller. If the radius is shorter, pressure becomes higher. And it is directly proportional to the tension in the walls of the sphere or the tube. So higher the wall tension, higher the pressure. Lesser the wall tension, lesser the pressure. Whereas with radius, higher the radius, lesser the pressure. Lesser the radius, higher the pressure. That is inversely proportional. So the relationship between pressure, radius, and tension is described in this. That is the way to remember that concept. So how does Laplace's law explain the prevention of small size alveoli collapsing totally? Here without surfactant, what happens? Air is going from the small alveoli into the larger alveoli, and this becomes totally collapsed ultimately. Whereas here, it is not flowing. Both the alveoli are inflated to some extent, and air is not able to empty from the small alveoli into the larger alveoli. And that is where the surfactant activity comes. So in alveoli without surfactant, the wall or surface tension in both and small alveoli is the same. Okay. On the contrary, the greater pressure is generated because of the smaller radius. So I told you that if the radius is inversely proportional. So smaller the radius of this, greater pressure will be there, so it will empty into that. Whereas surfactant prevents the collapsing of that alveoli and does not allow the radius to become small. So the surface tension reducing the properties of the surfactant reduces the tendency of the smaller alveoli to empty into the larger alveoli by decreasing the wall tension. And so here Laplace's law is applicable in function of reservoir bag in the breathing circuit. It's also applied for in various situations, not only for alveoli, it is used in machines with regard to the circuit and also the cardiac sizes. So how does it get applied in the reservoir bag, the breathing circuit? So the reservoir bag, what is the purpose of that? As a safety function, which protects the patient's lung from barotrauma. Okay? The radius of the reservoir bag increases when the bag distance either due to obstruction of flow or overfilling. And what will happen to the pressure inside when the radius increases? It decreases, thus preventing dangerous rise in pressure in the entire breathing system and consequently in the lungs. How is this law relevant to dilated cardiomyopathy?
There is the
As the
radius is
radius
high and the wall
increases,
tension is
the
lesser.
Dilated cardiomyopathy, heart becomes greatly distended and the radius of the ventricle increases. So naturally, the pressure should decrease or increase?
decrease.
Decrease. So the myocardium has to work more to increase the ejection or decrease the ejection. Therefore, to create the same pressure during ejection, blood much larger wall tension has to be developed by the cardiac muscle, and this may the dilated heart requires more energy to pump the same amount of blood as compared with the heart with a normal size. Okay, so that is how it is applicable in cardiomyopathy. The ventricle size increases, so radius increases, so there is a drop in pressure. So to eject the blood, the myocardium has to contract more than the normal myocardium. What are the uses of this?
In hyperkalemia.
And hypocalcemia.
Okay, used in hypocalcemic states like tetany, correction of magnesium overdose, or in hyperkalemia. Okay. How is calcium metabolism? What are all the hormones controlling the calcium metabolism?
Parathormone,
Calcitonin.
Vitamin D,
Calcitrol and calcitonin. Very good. What is the total serum calcium level? How is it distributed in the blood?
8 to 12 milligrams per deciliter.
8 to 12, 9 to 11.
9 to 11.
Okay. Millimoles. Any idea about millimoles? It is 2.25 to 2.55, 9 to 10.2 milligram. Distributed 50% is free ionized calcium, 10% is calcium combined with various ions like bicarbonate, citrate, phosphate, lactate, and sulfate, and remaining 40% is bound to serum albumin. Mention 4 causes of hypercalcemia.
Parathyroid adenoma.
Very good. Hyperparathyroidism.
Diuretics.
Thiazide diuresis. Very good. Okay.
Neoplastic syndromes.
Malignancy. Okay. Hyperthyroidism, malignancy, hyperparathyroidism, malignancy, thyrotoxicosis, vitamin D intoxication, and of course there are other 4 or 5 conditions. But exam just remember. What is calcium content in 10% calcium gluconate and 10% calcium chloride?
It is higher in calcium chloride, sir.
So 10% calcium gluconate, 10 ml contains 9.3 milligrams of elemental calcium, whereas calcium chloride 10 ml contains 27.2. Almost 3 times more calcium is present in calcium chloride compared to calcium gluconate. And this is a very common question asked in the exam. What are the actions of calcium?
Membrane stabilizer.
Membrane stabilizer.
Neuro.
It is needed for the sarcoplasmic reticulum, sir.
Muscle
Needed for
contraction.
muscle
Sarcoplasmic
transmitters.
reticulum is just a storage site for calcium. It is not needed for sarcoplasmic reticulum. It is from there only it is extruded into the cytoplasm.
It is a secondary
neurotransmitter.
neurotransmitter. Secondary messenger in muscle contraction.
Required for hemostasis. Coagulation, one of the important ions needed is calcium. It is vital for structural integrity of bone, needed for release of acetylcholine at the neuromuscular junction. Even before the stimulus, when it comes to the nerve signal comes to the neuromuscular junction, the entry of calcium in the presynaptic neuron only will allow the release of acetylcholine. And in skeletal muscle contraction as well as in cardiac muscle contraction, and as a neurotransmitter in CNS, which we saw is now earlier, alpha 7 nicotinic receptors. They allow this calcium channel opening up in the brain. Okay, so these are the 6 important functions. First and foremost, you must remember it is important for clotting. Second is it is the integrity of bone. The third is neuromuscular junction. Fourth is the contraction of both skeletal and cardiac function, and as a neurotransmitter in CNS. What is shown here? What are the other components that are not seen here?
Cardiopulmonary
Pulmonary
pipe.
pipe.
Okay. CPB circuit shows the cannula, tubing, reservoir, pump, and oxygenator, and heat exchanger. What are the other components of this system not shown in this?
Cardio.
Venting systems are missing.
Vent system, suction. Okay, right. Additional components not shown are suckers, vents, hemofilters, and cardioplegia system. Okay. Which cannula is inserted first before initiation of bypass, and which one is removed first before weaning?
Arterial, sir.
Cannula is initiated first.
Aortic cannula.
Aortic cannula.
Aortic cannula is inserted first before initiation, and during removal, this is the IVC cannula or the aortic cannula? This is the venous cannula which is removed. Okay? IVC cannula is removed. Arterial cannula is inserted, venous cannula removed first before weaning. How oxygenation is done in membrane oxygenator? What are the other advantages of this?
Diffusion, sir.
Diffusion, correct.
By
That is better,
diffusion.
but how? What does the membrane oxygenator contain? Right. Membrane oxygenation consists of hollow microporous polypropylene fibers, which are of 100 to 200 micron internal diameter. Blood flows outside the fiber while gas passes inside the fiber, thus separating blood gas phases, and oxygen gets transported across a pressure gradient. Okay? And they have lesser propensity for air embolism, give greater accuracy in blood gas control. And there are newer designs which have an integrated filter to manage emboli, thus making additional arterial filters unnecessary. What is the purpose of priming the CBP circuit? What are the effects of priming solution?
Prevents any air embolism.
Air embolism.
De-airing. It's called de-airing of CPB, done by that, and causes hemodilution, which improves flow during hypothermia. What dose of heparin required for an adult, and what is the target value of ACT to be achieved?
3 to 4
It is 2 times the body weight. 400 to 600.
300
ACT
units per kg IV before arterial cannulation with a target ACT of more than 480 seconds. Okay, so that is the answer for that. How is the severity of hyponatremia classified?
It is based on the onset.
Based on
and,
the symptoms.
Mild, moderate, and
Moderate
severe.
and severe.
Mild is 130 to 135. Moderate is 135 to 129. Severe is less than 125. How is true corrected sodium calculated in diabetic ketoacidosis? What is the formula that you will use to calculate the true corrected sodium? Okay, the answer is sodium corrected is equal to actually measured sodium plus glucose minus 5.6 multiplied by 0.288. Okay, this is the formula to assess. What is the neurological risk in acute hyponatremia? How is it treated? The cerebral edema, hyponatremic seizure, and reduced level of consciousness. These are all the neurological risks. And the acute hyponatremia, severe neurological symptoms treated with 100 ml bolus of 3% hypertonic saline. And this can be given intravenously over 10 minutes period. And the bolus may be repeated twice if severe neurological symptoms still persist. Okay. What is the guideline for correction of chronic hyponatremia? What is the risk of rapid correction in such cases?
It should be corrected with 10 to 15 milliequivalents every 24 hours. Rapid correction can cause central pontine demyelinosis. Okay, but the answer is chronic should be 4 to 8 millimole per day. Okay, not 10 to 15 milliequivalents. Okay, the equivalent of that will be 4 to 8 millimole. And the risk is osmotic demyelination, it is rapidly corrected. Yes, very good. So that ends the Osce for the day. Okay.
Sir.
Yes, sir.